people coming in, and hopefully, I think then we will start in the next 5 minutes.
Hello.
Hello.
Stay here.
Hi, Stay. How are you?
Good, thanks. Sorry for being late.
Sawubona wejob.
Ninjani mfethu?
I know who right baba.
Kunje internet enginayo mfethu ibuye yenze umhlola la, so hayi.
Kwenzeka kanjani umhlolo useKapa la kungenankinga ye network khona? Hawo.
Networks, networks, you know networks, they do what they do. Especially more sebenzisa phone, as you know.
Okay.
Yeah.
Okay. Hi, guys.
Hi, Nhlakanipho.
Okay, so I've just counted the number of people that have been able to join our Zoom meeting today, and I think at this moment we have about 4, 8, 12, 13 people that have already were able to actually come in online, and I can see number 13 is coming through, and I think that it will be fair for us to be able to start on time, because that will actually be able to give us sort of like a chance to be able to engage the presenter after the presentation itself. Since this is our first sort of like engagement and a Zoom meeting today, I thought that it was important for us to actually have some ground rules being placed before we start. For those that are not familiar with my face, my name is Dr Nhlakanipho Gumede. I'm actually the clinical manager, medical services in Edendale Hospital. And today we are actually talking about some latest updates with regards to COVID-19 as it relates to our ongoing problem in South Africa, but as well as in the world. And of course, we'd like to take this opportunity and appreciate Dr. S.D. Ntshalintshali for having agreed to actually give us sort of like an information with regards to the latest information that is available out there, which relates to COVID-19. So without any waste of time, I wish to advise you that you can put your microphones off, as I can see that it is off, so that we can allow the speaker to actually have a smooth presentation. After that, then we'll be able to unmute our phones so that we'll be able to engage. Please, can I just take this opportunity and welcome Dr. Ntshalintshali to give us the presentation for today. Thank you so much.
Okay, thanks Nhlakanipho for that introduction. Can you just take away your screen so that I can share mine? Okay. I'm not going to be long to allow for an engagement as we go towards the end of our presentation. But in a nutshell, I will be talking about evidence-based update of COVID-19. You will note that all the studies I'm going to be talking about, they are mainly are from the month of July 2020. We've been bombarded with information since like February this year when COVID-19 started to become a problem in China. And ever since, there's a lot of articles that are coming through. We have to sift very, very carefully to say what actually makes sense and what doesn't make sense. So I've tried to go through some of the important things that we've learned during the month of July. You will note that most of the things that are already general knowledge, I'm not really talking about, or some of the things that might have been important in June or May or April, etc. Just trying to figure out how to move my slides. Leave mouse. Okay. I put this slide just to inform you all that I'm not an expert in COVID. I'm not an expert in COVID, but I am. Well, I've had an experience with COVID. I've worked in Tigerbrook Hospital for 3 months in a COVID unit, and I'm currently in a COVID unit as well in Port Shepstone Regional Hospital since June 2020. So I've had like 5 months of fairly good exposure. But in any case, I don't think that there's anybody who can call himself or herself an expert in COVID, since he's still a developing disease, and we're still learning quite a lot about the disease. So yeah, if you ask me a question and say I don't know, just know that you asked one of those things that I'm really clueless about. And what we'll cover today, we'll talk about the mode of transmission, specifically about what's new on the mode of transmission, HIV and COVID-19, some of international studies and a study done that we're currently doing in the Western Cape, statins and COVID-19, which became a big thing because we know that metabolic syndrome, including diabetes and hypertension, are quite a problem when it comes to being a risk factor for COVID. And whether or not statins are an advantage, we're going to learn about that. COVID-19 and death, what are some of the factors that can make death certain or can make that one of the things that we should be worrying about? So basically, it's more in the form of a risk factor. If you see certain patients developing certain signs or having certain risk factors, you know that they are more prone to death than other patients. And we're also going to look at viral load. It's something that is new. It came new in July that someone decided to look, comparing the clinical presentation of patients and the prognosis of patients, to look at the viral load. Does viral load play a role? If your viral load is high, does it mean you're going to die? If it's low, does it mean you're going to recover? And also looking at antibody testing. We know that we've been doing the RT-PCR now, which is basically looking for the RNA material. But now there've been studies of antibody. We look at how can we use this and when is it appropriate to use them. Some extrapulmonary manifestations which have been noted recently. And I'm sure we all know about the recovery trial that was looking at dexamethasone. We're just going to look at some of the things that are a bit controversial as far as that is concerned. High flow nasal oxygen. You might see a lot of points here, but we're going to go through them quite quickly. High flow nasal oxygen, one of the modalities of oxygen supplementation that has been shown to actually make patients to improve and even prevent them from getting to a ventilator. So we'll look into that briefly. And lastly, we'll look at 2 trials that have come out in July, which are talking about vaccines. One trial from China and another trial from Oxford University in the UK. So there are some promising results on both, and we'll have a look at them as to what kind of vaccines and what are the results. All right, so moving forward, a statement was issued for the first time by the WHO around March, where they were telling us about that they know how COVID-19 is transmitted. We were then told to distance because it was believed that it's in a form of droplets, that these droplets, they do not really hang around much on air. They will fall down and they will then contaminate any surface. So that was the main issue, which was surface. The second issue was in people that when doctors are doing certain maneuvers, whether you are listening to a patient's chest, you tell them to breathe deeply, that can cause someone to cough. And if someone coughs, there might be aerosolization. Or when you need to intubate a patient, there might be actually aerosolization of the virus, and you find that then it becomes airborne. But now in July, actually started in June, but more in July, we heard about the story of, okay, it might happen that actually the virus is airborne. So meaning that in people that are not coughing or that are not going through any medical procedures, they can generate aerosols. And that actually would mean that you can get COVID as much as you can get TB or measles, which are known to be airborne transmitted diseases. So now this changes the entire ball game. It changes the entire ball game because then it means we can't be talking about cloth mask. We can't be talking about surgical mask. We should more maybe looking at N95s for everybody and things like that. And that we cannot be putting a lot of concentration just on cleaning surfaces and social distancing, that it's actually worse than that. Now, this is something that is based on experimental studies. If you look at this document, when you've got time, you can just go into the internet and look at this document, which came out in the July. It actually will tell you about close to 13 studies, which they are all experimental. Nobody will tell you that there was a randomized controlled trial where they actually proved that this virus is airborne. So we still sort of at limbo because we don't know what is true as far as transmission is concerned. All right, and looking at COVID graph that you see over here, it's a graph that was shared from Stellenbosch University. This one and the one that follows, in a study that the university is currently doing in collaboration with UCT. Here you're looking at Brazil and South Africa. These two countries, they've got the same sort of, when you're looking at them in terms of economy, they look pretty much the same. Maybe they differ a lot in terms of the number of the population size, Brazil having more population than South Africa. But if you look in terms of how the virus actually is been killing people, if I may put it like that, looking at the total number of confirmed deaths up to goes, if you look at your x-axis, it goes up to the 6th of July. You realize that it follows the same pattern. Now this becomes very important because we are looking at how Brazil, which measures Brazil put in place in order to try and prevent people from contracting the virus and also prevent people from dying. Remember that in 2014, Brazil had an epidemic with Zika virus, and Zika virus was one of the viruses that they had. It was airborne, and they had put in place measures to try and limit Zika virus, and it did not leave the country. It actually became a problem in Brazil. There were some few cases in Peru, etc., just the neighboring countries, but they managed to contain the virus. But looking at all of the experience that they had with pandemic, with epidemics, we are sort of in a better situation, if I may put it like that, if not in the same situation, if you look at those two graphs, without having had much experience. So there's a very little that we know in terms of what are the tricks that people can have, or what experience is required for us to be able to limit the spread or the death of people. We still don't know. Here, this is the study. If you look at your top right corner, just underneath the big headings, you will see it's entitled HIV and risk of COVID-19 death. So this is a population cohort study from the Western Cape. Basically, if I may put it in layman's term, they're trying to look at, is the case that HIV positive people with COVID die more than HIV negative COVID people? So that is a question that was posed, because if that is the question and you find that the answer is that yes, HIV people, they die more than HIV negative people, that would mean that HIV must be included as a risk factor. Because as you know, in COVID-19, we've got established risk factors like diabetes, hypertension, etc. But HIV is not part of that list. So this would mean that we have to include it, and that every HIV positive person then is treated as a high risk for COVID. What I can tell you that if you look at the numbers on the left, we had about 22,000 patients that were diagnosed with COVID-19, and out of those, 625 patients died. 14% were diabetics, as opposed to 8% that were not diabetic. 23% were hypertensive, and 16% were not. And you can see that in terms of age, it was mainly people that are older that actually died with a median of 63. Concerning people living with HIV, the proportion was similar in COVID-19 deaths and survivors. So that was sort of good news for the people living with HIV population. And as you can see, that 39% with HIV and 13% were without, in those that were less than 50 years. The issue that we'll see in the next slide that I'm going to show you, it seems as if people with HIV that are older, they don't do so well, but the younger ones, they really don't do badly. Here, it was 39% that died in the younger population, but the older population did well. So you will see that that's a Spanish study. This one is a South African one. So there was that inconsistency, that why are we seeing more or less than 50 here dying as opposed to those in Spain, which are in their 70s. The other thing that was a bit of a confounder was that the majority of these patients, they had other comorbidities, which were putting them as high risk for COVID. As you can see that 50% of them had diabetes, 42% were hypertensive. So you can't really say that it was HIV that killed these patients. So it's really still a bit murky in terms of saying, is HIV a risk factor for COVID or not? So this cohort study, as much as I was part of it, I feel that it did not answer the question. It did not answer the question of whether HIV is a risk factor or not. We're still at limbo. And this is the study from Spain. In Spain, in total, they've got 77,000 people who've got HIV and are on heart. And as you can see that they've got about 95% of them are virally suppressed. So they've got very good compliance in terms of people taking their ARVs. Now, what we learned from this, like I said earlier, is the age issue, which I'll show you now. But also, if you look at the highlighted area on the right bottom part, where it says NRTI, patients that were on tenofovir and emtricitabine, they did not die. They had 0. So if you were on the traditional tenofovir, you did not die. But if you were on tenofovir and alafenamide, the tenofovir and alafenamide is a combination that is normally used in hepatitis B infection. But if you were on those ARVs with alafenamide, you actually died as much as people that were on other regimens like abacavir and others that were taking second line. So there was a question mark from here. Does it mean that if you are RVD positive and you are on tenofovir and regimen, does it mean that your chances of getting HIV are low? That is also another question mark. We might have to see this being reproduced in other studies, because this was just one study from one country, which was Spain. The second issue that I was talking about, it was in terms of age. If you look at from the discussion point of view on the second line, it says risks notably higher in persons on ART versus general population. It's only in those older than 70 years. So that was the two things that I learned from the study. It was that tenofovir might actually have a protective sort of effect, or it's got an immunomodulatory effect in terms of preventing against getting the virus, or the virus getting worse when you have it. And also the fact that people that are older than 70 years are the ones that do not do well in the entire HIV positive population. Okay, so moving on, you will remember that I mentioned that metabolic syndrome, meaning diabetes, hypertension, dyslipidemia, and an elevated abdominal circumference, these things are associated with severe COVID. So they are known to be risk factors for COVID, and we know that statins, in so many trials that have been done before the time of COVID, statins were associated with decreased mortality in patients with metabolic syndrome. So here we have a study that was looking in hospital use of statins, whether it was associated with reduced mortality or not. And the conclusion was that in these patients with COVID-19, using statins was associated with a lower risk for all-cause mortality. So here you would see that it was not just for COVID mortality, but it was all-cause mortality. So when they looked at patients that were on statins and they've got metabolic syndrome, as opposed to those that had statins, I mean, those who had metabolic syndrome and not on statins, there was clear decreased mortality on the patients that are on statins. So if you have a patient that is having COVID or not having COVID, giving them statins, it actually prolongs their lives. And yeah, so that is what we learned from that study. Now, there was a very interesting study. I want to highlight about 3 things out of this one. This study came out it came out now on the 1st of July, and it was looking at factors associated with COVID-19 in 17 million patients. So this is what we call real world data. We don't have to go into statistics and try to convert our findings to understand them, whether they are significant or not. When you've got such a sample of 17 million, whatever that you get as an outcome, that's what you're going to take as the truth. You don't have to convert it. So in this real world data study, few things I want to highlight. Here on the left, you have got all the risk factors that we know of, right? Or some of the conditions that have been associated with COVID. But when you look here, firstly, there's age group, sex, there's obesity, and the next one is smoking status. I just wanted to spend a second there on smoking status. If you look at the smoking status, there were 3 categories. The first category were those who never smoked. The second category were those who are ex-smokers. And the third one is those who are currently smoking. At your x-axis, we've got a hazard ratio. Understanding that hazard ratios that are less than 2 are actually not that significant. We normally look at hazard ratios more than 2 that are actually significant. But if you look here, those who never smoked, if you take them as the baseline, right? Those who smoke, actually they died less than those who never smoked. And those who actually died more were those who were ex-smokers. That means probably those who have been smoking for some time and already they've got damaged lungs. So why I wanted to highlight this is that we do not have evidence that can prove that smokers, they actually die more. So if you look at things like the regulations currently in South Africa that are banning smoking, they don't actually have evidence for that. That is basically just an opinion to say, if you smoke, probably you'll have, you'll get the virus and you'll die, you'll have a worse case than others. But when you're looking at real world data, you can see that actually people who smoke, they might have a protective, if you may put it, we do not know, but they die less than people who never smoked, and they die less than people who are ex-smokers. That was the first point I wanted to highlight. The second point that I wanted to highlight was in terms of diabetes, right? Diabetes and hypertension, both of them. If you look at how diabetes and obesity. If you look at how actually the risk of dying is associated with these, it seems as if the bigger you are, the more you're going to die. So if your BMI is between 25 and 30, you've got a hazard ratio of about 1.2. But if between 30 and 35, and you're seeing your hazard ratio now, it goes up to almost 1.8, and it's beyond 2 if your BMI is beyond 35. And same thing applies if you look at HbA1c in diabetes. It's almost a replica of the BMI. Is that if you've got HbA1cs that are higher, well, here they use millimole per millimole, which are higher, your chances of dying are actually higher. Okay, and actually there is another study that is ongoing looking at HbA1cs and diabetes and COVID in Stellenbosch by the Department of Endocrinology. Those were the 3 things I wanted to highlight on here, that contrary to popular belief, smoking actually might be protective from death. Secondly, the fact that diabetes and obesity, they actually are linear in terms of how the risk of dying and the condition relate. The bigger you are or the poor control your diabetes is, the more likely you're going to die. Okay, don't sleep on me now. Okay. Since we're talking about death, this is the current situation in South Africa. This is the current situation in South Africa, where if you're looking at the 3 orange or brown lines, those 3 orange or brown lines, the middle line is what we expected our death situation to be in the country. And the dotted line below is if you were lenient, if we say the lower prediction, how it's going to be. And then if you were brutal in your prediction, that is the upper line, which is also dotted. But the reality is the black line. The black solid line, if you look at it, around April, in the week of the 22nd of April, it actually went below. And we know during that time that that's when alcohol ban was a reality, and we had less accidents coming through, and our casualties were empty. And we were still having lockdown, level 5 lockdown at that time. So it allowed for people not to be involved in accidents, and death actually was low. We know that after that, towards May, things were loosened up a little bit. And then where we see the peak, it was just after June, when we went into level 3, things started to peak. And also this is showing something that we've never seen before. You remember that people were saying, I know this thing of COVID is just a propaganda, it's not a reality, because people are not dying more than they used to before. But now we're seeing the reality that actually people are dying. People are dying more than we've ever predicted before, because these predictions of how the graphs are going to go, they are based on previous years. So looking at the trajectory in previous years, we can predict that, you know what, people were dying a lot around April. They start to die a lot around April, May, because of your holidays, etc. And around June, you can see a peak, and the other peak will be around December when we go back to holidays. But this time around, you can see that we are still steeply going up. This is a prediction from yesterday. As you can see that, actually from 14th of July, I mean, you can see that it's going steeply high, and we might be reaching peak. Some are saying in 2 weeks in 2 weeks from now or 3 weeks from now. But the situation doesn't look promising. Okay, moving along, I spoke about SARS-CoV viral load and the risk of death. This paper actually looked at the swabs that were done, and they correlated it with patients. They grouped them into 3 groups. If you look at your left, we've got the, I mean, it's highlighted there, the age, the obesity, diabetes, inflammatory markers, and outcomes. We're going to look at 2. We're going to look at, firstly, the age. You can see that it was divided, the groups that were looked at were divided into 3. Each group, so one was with high viral load, the other one was medium viral load, the other one was low viral load. The high viral load, they had 220 patients, medium viral load 216, and low viral load 242. And if you compare the ages among these, you can see that the ages are comparable. I mean, the low viral load was 63 years, the median, and you can see it was 69 here in the middle, and in the high viral load, it was 72. Also, when you look at BMIs were comparable. And actually, if you look at BMIs, you would realize that the people that had high viral load, they were in a better position in terms of the mean of the BMI, which is 27.6, as opposed to others that had 33. The other ones also had 33. So they were in a worse position. But with all of that, when you look at outcomes, now you go to the right side in the bottom column. If you look at outcomes, you realize that the ones that actually required intubation more are the ones in the first column, which is the high viral load. They were followed by the ones in the middle column, which is the the medium viral load. And the low viral load, very few, actually almost half of the high viral load, they required intubation. And when you look at death, in hospital mortality, if you go down about 3 lines from the intubation, you will see that same thing occurred. A lot of the ones that had a high viral load, they died, and as opposed to the medium and the low viral load. This basically what it translates to when we are looking at it is that very soon we might have to look at the viral load when the patients are presenting, because that can tell us in terms of risk stratification, who do we spend time more because they're going to do worse, and who do we prioritize in terms of jumping into them. And so it will help us in terms of triage, because triage doesn't just happen at the level of casualty, it happens even at the level of ICU. You can triage which patients you're going to ventilate or which patients you're going to manage conservatively. So as I mentioned earlier, is that high viral load mortality versus low, you would see that the hazard ratio is sitting at 6. And I said earlier that the hazard ratio more than 2 is actually significant. If you look at the graph quickly on the right bottom area, that is a Kaplan-Meier plot where you see it's comparing probability of in-hospital survival versus the days after admission. The line that is on top is those are the guys with low viral load. So the ones with low viral load, the chances of survival are much higher, as opposed to the one that's at the bottom, which is the green line. The green line are those with the high viral load. Their chances of surviving when they are inpatients are actually declining with time. The more they spend in hospital, the more they're going to die. So these patients, as I said, that it will help us in terms of triage, and it will help us also into saying, if I know the virality of a patient and this is the amount of viral load, what is it that I need to do, and where do I cap treatment, or where do I escalate treatment? Okay. The issue of testing, like I said, we've been using RT-PCR for testing. And we've been asking about antibody. When are we going to use antibodies? And is there a point in using antibodies? Now, antibodies, you must have an infection first before you have them, of course. So it won't really help us in terms of identifying our patients early, because you will wait for them to develop. Whereas RT-PCR, you pick up people early with the infection, even without symptoms, even without the antibodies being formed as yet. But apart from that, what we've noted in terms of the antibodies is that if you give more time for antibodies to form, the better your results. But if you do it early, the poorer the results. This is the what you see here in this slide, which says the combination of IgG and IgM had a sensitivity of 30% if for 1 to 7 days, 2% 8 to 14 days, 91% for 15 to 21 days, and 96% to 35 days. If you look at this graph here, this is a meta-analysis which compares all the studies that have been looking into antibody testing. So in total, there were about 23 studies that were looked at, and most of them, they looked at, if you look at the first 5 on your left, they were looking at IgG. So the ones that were looking at IgG, like the first one used 23 studies, you can see that it was only at day 30, just only 30% that at 7 days, they found it was positive. Whereas it had to be around 68% after 8 to 14 days, and sensitivity gets better as the time progresses. But what I want to highlight here again is that it would seem that the best combination, it's not to use IgG or IgM or IgG-IgM combination. If you look at the very last study that was done, the problem is that it's only one study and they only have 12 samples as compared to other studies which are more significant. The IgG and IgA combination at the bottom, it seemed as if in terms of sensitivity, towards the end, it goes to 100% at 22 days. A lot of studies didn't do that. The thing with IgA, when it's combined with IgG, actually the results are much better, although it's not depicted here, as combined with other immunoglobulins. So you might be looking at the combination of IgA and IgG hoping that the two can be positive much earlier. And we need more studies as far as that is concerned, because when you're looking at this meta-analysis, although studies were 23, we still have a lot of gaps that we do not know. So antibodies, I feel that for diagnosis, maybe not. Maybe if we want to check for herd immunity, which is what we're hoping for, but now we know that there's recurrence of the virus in some of the cases in China. So you might find that if you've got immunity against the virus, you lose it over time and you can get the virus again. So we'll see as the time continues. This is another paper that came through now in July, which talks to extrapulmonary manifestations of COVID. And I mean, if you look at the pathophysiology of COVID, it makes sense for the virus to be able to affect all organs. If you look at your right lower, I mean on your right bottom area, you would see you've got a blood vessel there. And that blood vessel, on top of it, you've got number 3 and number 4, which are endothelial cell damage and thromboinflammation and dysregulation of immune response. These two things, they affect blood vessels. But now blood vessels are found in all organs in the body, which means your liver, your kidney, your lungs, everywhere there will be endothelial cell damage, and there will be what we were calling a storm, so sort of a cytokine storm, because these cytokines, mainly IL-6 and tumor necrosis factor, they are everywhere. They are everywhere, and they can trigger immune cells to start destroying the blood vessels in any organ, such that if you look at organs that are involved in COVID now, apart from the lungs, you get affectation of the brain. That's why you get headaches, dizziness, encephalopathy. There have been cases of Guillain-Barré, and the fact that some people can't taste, can't smell, some have got strokes. You get kidney involvement with acute kidney injury. There have been elevated hepatic enzymes. 60% of patients, they present with diarrhea. So there's also GID involvement. There's deep vein thrombosis and PEs. Even in young patients, we've seen this. There's cardiac manifestations of myocardial infarction or broken heart syndrome. And we've been battling with a lot of patients coming in with DKAs. And the type of a DKA that does not respond to the normal protocol, you should think that the patient has got COVID. So you've got DKAs that for 3-4 days, they are not getting better. You give him fluids, insulin infusion, but still you must think that they've got COVID, and you must swap those patients. And that might be the only presenting manifestation. And you've got dermatological manifestations, of which there are many different types of rashes, but mainly it's more like your urticaria or your allergy type of rashes that you get. Described have been in the feet, in the hands, but there's a lot of different types of rashes that are coming through now. And most of them, they've actually done biopsies, and they've identified the virus and the affectation of the blood vessels. Now, like I said, because it affects blood vessels, it will, of course, affect every organ in the body, unfortunately. Okay, moving on to the recovery study, which was looking at dexamethasone. There were a couple of things that did not go right here with the recovery study. And the first thing is that, you know, before studies, they become popular knowledge, they actually go through a process of peer review. And in this case, we saw that the guys that were in the forefront of the recovery study, they were actually talking to the media about the results of their study. And it became popular knowledge through the media that you give 6 milligrams of dexamethasone daily and your outcome is better. And this was before a peer review. So that made sort of the scientific community to be a bit confused. How do these people talk about their results when nobody has actually looked into their methodology, if everything that they did was according to the scientific method of research? So that was one of the first things that did not make sense. The second thing that I want to highlight is that there is a hype about dexamethasone, how it works, etc. But if you look here, you will realize that patients that actually it works well for, if you go to line number 1, 2, 3, 4, 5, 6, 7, where it says in. So if you look at the people that are taking dexamethasone, it says in the dexamethasone group, the incidence of death was lower than that in the usual care group among patients receiving invasive mechanical ventilation. And it was 29% versus 41%. So the dexamethasone group, they had an improvement by about 12%. And among those receiving oxygen without invasive mechanical ventilation, it was almost the same. So people that were getting dexamethasone and they did not have severe COVID, it wasn't severe enough to go on an event, they only had a 3% of improvement. So that's not good enough. It's not good enough for us to start putting people on steroids that have got so many side effects just because you want to look for that 3%. And if you're looking at a number needed to treat, you need to give steroids in the moderate, mild to moderate disease people. You would give dexamethasone to about 8 patients for 1 patient to, 23 patients for 1 patient to benefit, as opposed to the ones on event. The ones on event, you must treat 8 of them and 1 would benefit. And that's a lot actually in terms of if you're looking at in terms of the side effects, the benefit versus the risk. I think the benefit probably in the severe COVID, the ones that are ventilated, you might have to use steroids. But the ones that are not ventilated probably is not a good idea, because you're looking at really a few people getting a benefit out of that. The other issue that I did not mention is that if you look at your right-hand side, it shows you there the coronavirus, how it's identified by the cell presenting, by the antigen presenting cells, which is the dendritic cell in this instance, that identification of the coronavirus, you need those dendritic cells to be able to function properly. And if you give steroids like dexamethasone, they actually affect that process of identification. There are certain molecules in the surface which are called the PAMs, the pathogen-associated molecular receptors. If they can't identify well this virus and present it to your T cells, then this virus continues to destroy the cells as it does, which is why steroids probably are not a good idea early in the disease, because it can cause the viremia to be very high. And also steroids are not a good idea in people that are not really sick. We would rather give those who are really in ventilators. Apart from that, there are other treatment modalities that have shown actually to have almost a similar effect, which was actually early on in the studies that were looking at alternative therapy. Tocilizumab and sarilumab, which are IL-6 inhibitors, they've been used in Italy, and there was a promising results, just that there were no studies that were done to replicate the effects, right? And the same thing with cetuximab and baricitinib and anakinra, they were also used, and we found that there was some evidence that showed promise. But now remember, we do not change and use the drug for condition in just 1 or 2 studies that have shown a benefit. So we need things like meta-analysis after a lot of studies have been done to see if really there is an effect in using those drugs. So what we're seeing in dexamethasone, the message is what we're seeing with dexamethasone is not something new. We've seen this with other drugs. I'm not really sure why there's a big woo-ha about the dexamethasone. And like I said, there've been some questionable tendencies from the authors of this paper and from the researchers, in that they publish their information before even a peer review could happen. So that makes one wonder, why dexamethasone? Anyway, in conclusion, the recovery study authors, they say in patients hospitalized with COVID-19, the use of dexamethasone resulted in lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen alone at randomization, but not among those receiving no respiratory support. Right. Lastly, we come to our vaccines. So like I said, the study above, they looked at safety and immunogenicity. You remember that when a study is going through through a phase 2 or early phase 3, we're looking at mainly safety of the drug before we can really comment on whether the drug works or not. But I see in these studies, as I'm going to show you the results, it seems as if they were doing things concomitantly. They've changed the rules of randomized controlled trials
You see a phase 1 within a study that is in phase 2 and a phase 3 within a study. It's something that we've never seen before, but I think because of the urgency of the matter that we need a vaccine, they had to tweak the way that they do things at this point. So the first study from Oxford, they were looking at this KDO X1 nCoV-19 vaccine against the SARS-CoV-2. So I'll show you the report now, just to mention that it was a single blind randomized controlled trial. So the patients did not know what they were taking, but the investigators, they knew what they were giving them, whether it was placebo or it was actually the vaccine. And the second one, it's the one from China. So the Chinese, they did something a bit different. They used another virus, which is adenovirus. They are using it as a vehicle to introduce some of the antigens of COVID-19. So they used that as in healthy patients that were 18 years and older, but this one was a double-blind study, so not the researchers nor the participant know what they are taking. It's something that becomes revealed in the end. So looking at the first study, I'm not going to go into the entire methodology of how they did the study, but some of the findings that are promising is that neutralizing antibody responses against SARS-CoV-2 were detected in 91% of participants. That was 32 out of 35. And that also, there were no strong safety issues. There were no big safety issues with the drug. So it actually showed some promising response. And the fact that also when they boosted the drug, it actually improved, which means they had to give another dose of vaccine. It actually gave a better response against SARS-CoV-2. So we still, like I said, this is now on a phase 3 ongoing trial. So we're still waiting to see what is the actual outcome and how long the immunity lasts. The second study, where they used the adenovirus to introduce some antigens from the SARS-CoV-2, it also showed promise. In this study, actually, if you look at the seroconversion rate, was sitting at 96% of participants, and that is something that is very promising. It means, and also there were no serious adverse reactions that were noted. So we just need to keep our eyes open and see, maybe in the next few months we will be hearing that some of these vaccines are actually available against COVID-19. Like I said, the biggest question now is, once we are vaccinated, how long does those antibodies, how long do they last? Nobody knows. So we will see. We'll have to see these studies as they continue to gain more of that knowledge. And that's where that 18 months of wait from March actually comes from, because there are a lot of things that have to happen before a vaccine is released to say it's safe to be used in humans. High flow nasal cannula oxygenation. It is something that I personally have experience with, as we've used in Tygerberg Hospital. I'm sure Dr. Sithole can agree with me. But what happened in the beginning is that we were intubating all these patients that had severe COVID. Once you could not maintain your sets and you are on maximum FiO2 on a face mask, we then will intubate you, or what we call a PF ratio, where you compare a PO2 and FiO2. But what actually transpired is that initially around March, we had a mortality of 100% in our ICU. Everyone that we intubated died. And we tried to look at other strategies. So from northern Italy, in Lombardy, they had, where the situation of COVID was the worst, actually, they had tried high flow nasal oxygen, simply because they did not have ventilators. So they were intubating everyone until they did not have ventilators available. So they tried proning, people did not get better, and then they gave them high flow nasal oxygen. High flow nasal oxygen, what they noted was less and less people required mechanical ventilation once they were given high flow nasal oxygen. So how actually it looks like is in this way, that it's connected to a normal oxygen point, and it goes through a humidifier, and you get this cannula that comes through the nose. What I can inform you is that in South Africa at the moment, If you want high flow nasal oxygen, you get it in about 5 to 6 weeks time, because there is a very high competition between state and private sector. Everyone is ordering now high flow nasal oxygen. I know that in Cape Town they started to order it months ago, but now when you're starting to order, all of a sudden we don't have stock. We have to wait for stock to come from overseas. But yeah, it's one of the ways that has been shown time and time again. There's another study that came from New York. It showed the same thing, that high flow nasal oxygen actually is better. So as they concluded, the authors of this paper, they said high flow nasal cannulated oxygen is an effective treatment modality for COVID-19 associated acute respiratory failure, particularly in patients with mild to moderate ARDS and in negative pressure rooms, which most of us don't have. It could be a viable initial alternative to mechanical ventilation. So those patients with a very low PF ratio, you would actually use high flow nasal oxygen first before you consider ventilating them with a ventilator. I think that is where I end, and then I'll hand over to Nhlakanipho if there's any questions.
Thank you very much, Dr. Ntshalintshali, for the great presentation. I feel very excited, but also confused at the same time. I think, you know, the way that you actually explain some of the data elements that are involved in some of these research articles that you've just highlighted on actually tells us a lot that there's actually a lot of work that is being done in the background in trying to manage COVID-19. And unfortunately, the people only see the guidelines that talk to just the public regulations when it comes to COVID, and they forget that there's a lot more that is actually happening in the background when it comes to how we better prepare as healthcare workers in terms of how we manage these patients. So I would like to thank you very much for that presentation, and open this platform for questions if anybody has any question, please. You can unmute yourself and talk if you would want to ask a question, please.
Good evening, Babu Ntshalintshali. It's Ntantla Masuku. Let me just break the ice, because I think maybe some people are just scared to talk to you, as you are a big guy now. Yeah, no, I'm glad. This is a very good presentation. I've also been like looking at different articles and studies, even siphoning through the SASA website. So there's a lot of things that you've said. Even on my Facebook page, sometimes I have put some legal information about other things, especially with the issue of tobacco. I've also like looked everywhere. I've never seen any study that showed that tobacco was a risk, was like a big risk factor for dying in COVID-19. But then people just go by that popular belief that because smoking usually causes problems with lungs, and then they will think it's it is the right thing to ban smoking. Well, the other thing is, although we can't do viral loads to everyone to actually elucidate which patients might die or not, but I don't know if maybe you have checked things like D-dimers, because I've seen in some studies that they use D-dimers to check on that fact that even just before the test is being done, the COVID test that you do, that you are doing, the PCR, that in some countries like in the USA, they do a series of tests, including ultrasound, instead of CT scans, because now to do CT scans on all these patients is going to be a very big, it is a big problem, because CT scan, every time you put a patient in, it has to be cleaned and sanitized and all that. It takes a long time. But ultrasound, actually, I was reading on the paper that Lara also put on in the group that you guys wrote, in terms of X-rays. But ultrasound, I think it has been taken as a gold standard in diagnosing or in seeing some problems that come with the COVID-19, even earlier than the X-ray manifestations. So I've talked a little bit, a lot, and misguided here, but I'm just asking about the D-dimers and your perception on ultrasound. I know that ultrasound needs some training, but the way I see the signs that may make you think of COVID, I think it's very easy to see in ultrasound, because it's just the normal things that you see with pneumonia, sometimes like the P lines and all that. What is your take on the early use of ultrasound and the prediction of death using things like D-dimers, and even maybe many more that you've seen, like the one that you just mentioned, especially the viral load?
Okay. No, thanks, Jonathan. I think you're raising valid points. I'll just mention one thing. I was actually presenting the latest updates in July, if you remember.
Yes. Yeah.
Actually talking about the two, D-dimers have been mentioned in managing these patients. Problem with COVID, we have understood now that these patients, they tend to make a lot of microthrombi. And you remember that D-dimers are a product of that fibrin disintegrating. So when it disintegrates, one of the things that will be able to do D-dimers. Now, with COVID already, you've got all of these manifestations. It becomes non-specific because you don't know how to interpret it, but we know that a lot of patients with COVID, they will come up with a high D-dimer. We do not use one test to make a diagnosis. We use a sort of a number of tests. So if a lot of things are pointing you towards that direction, we actually use that. The other test that we actually use is if you've got a lymphopenia with a normal lymphopenia. So we call it a neutrophil lympho. It's an NL ratio, a ratio of neutrophils to lymphocytes. Normally you wouldn't just get an isolated lymphopenia unless you've got things like HIV, etc., or some autoimmune diseases. But in those patients that do not have all of that, and all of a sudden it's got low lymphocyte count, and it's got D-dimers that are elevated, and you've got a high CRP, then you start thinking, maybe I'm dealing with COVID. Talking about your ultrasound, it is true. Ultrasound is one of the things, or rather diagnostic modalities, that has been introduced now in terms of lung studies. The issue, to tell you the truth, is experience. There are very few people experience with ultrasound of the lung. I remember that we had Prof. I remember we spoke to Prof. Irusen, who's a professor in pulmonology in Tygerberg. He was talking about the same thing, that people have to start learning how to do ultrasound of the lung, because nobody actually has been looking into doing ultrasound of the lung. But it is true, it has been described. They see a lot of changes, even the thrombi that happen. Because remember, when you look at use of COVID in the lung, it mostly affects the areas of the lung that are immediately under the pleura. So it's more for peripheral, and it's with ultrasound because it's just right there underneath the pleura. But the issue that I unfortunately I foresee is that experience. Even ultrasonographers that we normally send our patients to, very few of them have been exposed to ultrasonography of the lung. So it is a challenge. I want to think that mostly in New York, where this was identified, it's probably people that have been doing these studies and they are well vested with how to use ultrasound in the lung.
With us, I think it's a bit difficult. We use ultrasound sometimes if there's an effusion that is small, you want to tap the effusion, but not for diagnosing a parenchymal disease like a viral pneumonitis in this case. So it's a bit, because you will have to know what to look for to differentiate it from other other diseases that will affect the parenchyma. But it is something that has been mentioned, so you're quite right.
All right, thank you very much. Is there any other question that we can take? Because of time, we're just about a minute or two before actually 6 o'clock. But I think that we can still take a couple of questions for Dr. Ntshalintshali.
I just have a comment.
Please go ahead.
Good afternoon, everyone. Most of the studies that I've looked at, which talks about HIV and COVID, apart from the ones that you presented from Cape Town, I've realized that most of them have been done in Europe, in Spain, and some in Italy. I think the most cases that they have were 33, and then the rest were just, 5, 8 cases, and they couldn't actually come to a conclusions because some of those studies were contradicting each other. So Ntshalintshali, I've spoken with you with regard to this. So I think us as South African being the harbor of HIV, we need more of this type of studies, to further come up to a conclusion when it comes to HIV and COVID. Having studied in KZN, I know that we have more HIV than Cape Town, where most of the studies have, in fact, most of the studies regarding COVID in South Africa, they've come from Cape Town. So I'm challenging you to do something from KZN, so that we can address this type of issues when it comes to HIV and AIDS and COVID. With regard to the D-dimers, most of the autopsies that have been done, first of all, we know that diffuse alveolar damage can be caused by so many diseases, and COVID has come to the party as well. But what they've realized with COVID is that most of this, when you look at the lung under the microscope, you see that they do have diffuse alveolar damage, but most of them, they've been accompanied by fibrin thrombi, which is usually not a common occurrence in cases of diffuse alveolar damage caused by any other causes. So hence they came up with, when you have diffuse alveolar damage and fibrin thrombi, it was a novel findings for COVID. Therefore, most of those cases were done before they even died in Italy. Most of them, they had done D-dimers, and they've realized that most of those cases with high D-dimers, they had those fibrin thrombi. Hence, they also recommend that most of the patients with COVID, they must always do D-dimers. You will also realize that from those findings, it was also suggested that probably this patient may do well with anticoagulations. I don't know how far are they with those things. So I just wanted to come to Jonathan comment about the D-dimers, that I think they are very important. I don't know how often do you guys do them in clinical medicine, but there's been proven that 80% of the patients with high D-dimers, they present with DAD and fibrin thrombi, which is a novel findings for COVID-19. Thanks.
Thank you very much.
Thanks a lot.
We can still take some more comments and maybe questions.
Good evening, colleagues.
Yes, go ahead.
Hi, I'm Dr. Gumede. I'm just going to have 3 questions. Well, I'm not really into internal medicine, but I know this is something that we've also been seeing with our surgical patients. who are post COVID, and some of colleagues that we've encountered the similar experience. So firstly, I wanted to know, do we have any local statistics in terms of the immunity that you get after your first COVID hit? And two, in terms of reinfection, so because I know you get maybe I know the something guidelines, it takes 3 to 6 months to get reinfection. So when you get the secondary reinfection or exposure, does it become as severe as the first one, or the second attack is actually the one that's more severe than the initial one? And I also wanted to know what's actually proven to help with the intermittent chronic cough that most people are getting post-COVID. Thank you.
Thank you very much, Dr. Gumede. Maybe Dr. Ntshalintshali is going to start responding to rather a comment by Dr. Moshawe and his request in terms of some kind of research work that needs to be done in the province, and also then go through and respond to the 3 questions that have been posed by Dr. Gumede. Dr. Ntshalintshali, are you still there? We might have lost Dr. Ntshalintshali. But if Dr. Ntshalintshali is not in, is there anyone who maybe want to sort of like take on the questions that have been posed by Dr. Gumede in terms of the immunity and also the severity of the cases from the first and the second sort of like onset of reinfection with regards to COVID-19?
Hi, Taga.
Oh, Doc is back. Thank you.
Yeah. No, sorry, man. I had network issues, but I didn't get the question.
So first of all, I wanted to see if you have any sort of like comment with regards to what Dr. Moshawe had highlighted about the need for local research in the province with regards to what he was
yes. You know, it's very unfortunate. It's very unfortunate that when it comes to HIV, actually, KZN in the world, if you look at population per square meterage, we actually have the highest number of HIV infected people living with HIV, if I may put it like that. So we're supposed to, which is why Bill Gates decided to build that huge building for HIV and TB research at UKZN, but it's not being utilized to its potential. People are ending up doing other things in that building because we are not actually very much people that are motivated with research. I just hope that seeing that things are changing, our behavior towards research is also going to change, that this COVID might motivate us to do more and more research and change the ways that we've been doing things previously. We shouldn't be hearing about how to manage HIV from outside the country or in other provinces. It should come from us telling them how things are done, because things are happening right here. So I hope, that's my only hope. I think Moshawe is very right. We need to change the way that we're doing things currently and realize that research, it's only us that can start something. And I think we've got a very good question now, because even the study done in Cape Town, for me, it did not answer questions that I had about HIV. And there were so many confounders because people also had diabetes, hypertension. About 50% of them had diabetes. So you really don't know, did they die because of diabetes, or was it the hypertension, or what's going on? So all of those those questions we can answer if we were diligent with wanting to have answers to those questions and actually engage in research. But I guess this is the start of something. What you started, Dr. Gumede, it might actually lead to us going that direction.
Right. Thank you so much. And then there was a question from Dr. Gumede about the issues surrounding immunity. You know, whether, you know, is there anything, there has been sort of like stories that have been shared with regards to research where we've been told that people that have been exposed or have tested COVID-19 or positive actually had immunity for a certain period of time. What does it pertain to? Is there any validity with that information? And as well, she was asking if the person who gets COVID-19 the second time, is the disease progression much far worse than the person that actually gets the disease the first time, or is it the other way around?
Okay. Unfortunately, we can't give answers to those questions simply because of the numbers of people that have been reinfected. We're still talking case reports. So we are not in really randomized trial, controlled trial level where we can tell you, we've compared people and this is what we find. So in case reports, we might tend to exaggerate what they say, but it's only 1 or 2 cases, and we can't really take that as knowledge or something to actually share with people and say, this is what is actually happening. What I would say is, in China, there were case reports from China, and what the Chinese actually wrote, I think this was in June, they spoke of a period of about 3 months, because there's people that presented with reinfection. One of them was in February, had COVID, and about 3 months later, the other one was in January, and about 3 months later, had another episode. But now we can't really take that and say, okay, no, it's 2 to 3 months, you can have a reinfection. If you remember very well, we've got a lot of viruses that all of them, our immunity towards the virus, it's not the same. For example, the flu virus, we get a flu shot every year because it lasts for about one year or one season. So it does not last forever. But if you look at vaccines like hepatitis B, it can take you about 10 years. You might not need a booster because your levels of immunoglobulins are high. But then other infections like polio, you get your polio droplets, and after that, you will never need it for the rest of your life because you've got immunity for the rest of your life. So it's like with COVID, we don't know how it's going to actually respond. Even these vaccines that are being generated now, we still don't know, are these vaccines going to generate a type of immunity that's going to last for a season, or is it going to last for 5 years, or is it going to last forever? So we've got those questions, and unfortunately, we don't have answers. And as far as reinfection is concerned, who is at risk for reinfection? Is it everyone who's been infected before, or some people they get immunity and not get infected later? Nobody knows. I think we are still there. Or if I can answer that question, it would be pure speculation. We really don't know.
All right, thank you much. We've got a hand from Dr. Sanele.
Stembiso.
Thank you very much.
Oh, Stembiso there?
Yeah, this is Stembiso. Guys, this is my observation, right? It's just a few things to ponder about. I'm here in Tygerberg, and what I've noticed is post-COVID neuropsychiatric disorders. I don't know if anybody has seen anyone presenting with post-COVID neuropsychiatric disorder or psychiatric disorders. And like Sipho said, it's a disease everywhere. Its vessels are everywhere. It's in the brain, it's in their hearts, it's everywhere. Like a couple of days ago, I saw a lady with systemic sclerosis who presented with high D-dimers post-COVID a month ago. Post-COVID, now was referred as a suspected pulmonary embolus patient. However, she did not have a pulmonary embolus. She just had post-COVID pulmonary fibrosis for probably from the systemic sclerosis itself or the COVID. But now the main issue here was, doc, listen, man, I think I have the COVID. They present with these neuropsychiatric disorders that we're not sure where does it come from. Now, this is just one of the areas that we have not touched, or we have not researched, or we have no papers written. So I'm just saying, if people could be okay right now in KZN and anywhere else, we're still in trouble. We haven't seen people who are post-COVID, but now, yeah, this side there are people who are post-COVID who present with different systemic problems. So I would urge, if anybody who has an interest in looking at such issues, just to think about it, what is going on. Maybe if the resources in Tlaga, if they're there, maybe we put, as Mushan was saying, look, we have an area there in Durban which is underutilized, or whatever that is being underutilized. Can you just look at it and then let's grow? That was just my comment, nothing more. Thanks a lot, Bafit. Thanks, Sipho,
very much, Dr. Stole. That was a very valuable comment and a contribution, because obviously this actually opens up a sort of like a need for us to be involved in research work that relates to, you know, how things are actually happening. And I actually see this type of engagement as a platform to which people that are really interested in some of these things could actually collaborate and start forming part of very opportune sort of like groups of people that are actually looking to explore, you know, some of these research questions that we have that we actually want to have answers to. And I'm actually looking forward to sustaining these types of engagements and actually getting also people that have not been exposed to research work to start learning from the work that you guys have already been involved in. And I'm hopeful that we can actually get to a point where we feel comfortable with the research work and actually getting more and more involved in research work moving forward. So I still see a hand from Dr. Sanele from the iPad.
Thank you very much, Dr. Gumede. Good evening, gentlemen and ladies. Thank you very much, Dr. Nhlakanipho, for your very enlightening presentation. The research on cigarettes. Is there anyone looking at? I see the issue of current smokers and the smokers and people that have been smoking before. Is there anyone looking at, in terms of the people sharing cigarettes, if there is a transmission that is high there, in terms of sharing the cigarettes, maybe, which might be the reason, one of the reasons why the issue of shutting down the cigarette industry. Is there anything that they are doing there? Thank you.
When people gall, they put saliva on the paper.
Yeah.
I think Usanele, you've got a point. You've got a good point, because we know that you'll have COVID in bodily fluids, and saliva is one of them. And now if people are sharing, I think it stands to reason that probably if you've got COVID, you can give it to another person. But I haven't had anyone talking about it in that point of view. You see, those are kind of inquisitive thoughts that we must always have and try to give answers to through research. But it's quite a good question. It's quite a good question. We can actually ask people that have got COVID that are smokers if they share their cigarettes, and we can get that information. And there you've got a research paper. It's not something that's very difficult.
Yes, Dr. Nhlakanipho, unless you need to ask Dr. Nkosazana Dlamini-Zuma to actually then decriminalize the sale of cigarettes, so that we can have a good sample of people that are smoking. So that we
Yeah, no. Hey.
All right, ladies and gentlemen, the time right now is just after 16 minutes after 6. I would like to take this opportunity again to thank Dr. Sipho Ntshalintshali for having given us quite a very detailed and a very interesting presentation with regards to the latest information on COVID-19. And I really do appreciate the effort that you've put and the type of information that you've actually shared with us. It was really enlightening, and I hope that we can use this information for our own good use. But I hope that it can actually spark an interest into research, because I think that this may be as well an opportunity to sort of like get as many of us as possible into the world of research and innovation, so that we can be able to influence how the medical care is actually being provided to our patients. So, ladies and gentlemen, let's please clap hands for Dr. Ntshalintshali.
Thank you.
Thank you. Thank you.
Then can I declare, unless Dr. Ntshalintshali, you want to say something to round up, and then we'll close after you.
No, just to thank the opportunity and hoping that we'll see more of these happening. Thank you. Thank you very much for the opportunity.
All right. Thank you very much, ladies and gentlemen, for coming in. We had a total of about 18 participants that went down to 13. So that was a very good participation. And I'm hopeful that in the near future, we're going to also have another engagement like this one. Thank you very much, and good night.
Okay, bye.
Sure.
Thank you all. I'm here. That's why I couldn't even participate. Thank you. Thank you so much, Sipho, for sharing. Yeah, bye.
Bye, Londiwe.
Bye, Londiwe. We didn't see you there. You had work.
Yeah.
All right, great.